All right. So today, I'll just put my disclosures up there. Usually my opinions are not mistaken for the official policy of the US government, but I am a VA employee, so I have to say so. And I always like to start talks with a patient perspective. This is a veteran patient who had experienced life-threatening opioid toxicity or overdose. In his case, he'd not taken too many of his pills. It was simply that he was adherent to the regimen he was prescribed and nearly died as a result. And this quote is from a qualitative study after he'd found a new doctor and been tapered down on his opioid medications. He points out that, his doctor was a good person who cared about him, who wanted to relieve his pain. But he was overly taking care of me, he said, and he didn't think about the side effects of what he was doing. And I think that this is a really great quote to illustrate a problem that we have with an iatrogenic epidemic, which started with many good intentions and has really ended up with difficult and terrible consequences for many of our patients who we were trying to help. So I'm going to talk briefly today about some barriers to improving pain management practice. And I'm a pain researcher, so my focus is chronic pain management. My focus wasn't supposed to be opioid management, but opioids have become a crisis in primary care and in chronic pain treatment. And so that's how I ended up studying opioid therapy. But really, I think the important thing here is improving pain management. And so that's my context that I always talk about. I'll talk real briefly about the National VA Opioid Safety Initiative, which was really rolled out in 2014. And then I'll talk a little bit more about our experience at the Minneapolis VA, where we started an opioid safety initiative in 2011. And when I say we, I should say that it was not me that started this. I was not the leader of this. I'm a researcher there, and certainly I've been around, but it was a clinical leadership initiative that really started and changed our practice. So I'm going to talk about that. It wasn't a research study. It was really, this is more of a case study I'll talk about of a health system that made big changes. So first, talk about some barriers. So this is the solar system with OxyContin at the center. And I'm not picking on OxyContin here. I am, because Purdue deserves it on some level. But really, this isn't specific to OxyContin. It just happens to be an OxyContin tablet standing in for opioid therapy. And really, this is my first barrier, and that is that opioid therapy has been the absolute center of chronic pain management for the last couple of decades. And this is a huge barrier. For those of us who trained in the last 20 years, what did we learn about pain management? I learned some basics about peripheral nociception, and then I learned about opioid pharmacology. So what do we have to work with? We have a large workforce that has been primarily managing pain with opioids and doesn't necessarily have a basic background in the mechanisms of chronic pain, how to assess chronic pain and the effect of pain on someone's life, and how to manage that pain. We've really just been managing opioids, and everything is revolving around opioids. So this is an enormous barrier to, I think, undoing our overuse and over-reliance on opioid therapy. This here is opioid therapy at the center of a black hole, meant to represent really time and effort in primary care. So what are we doing in primary care for pain management? We're managing opioids. We're monitoring opioids. We're checking drug screens. We're signing consents. We're renewing prescriptions. I mean, this stuff takes a lot of time. And it takes up most of the time and energy that we have that we could be allotting to chronic pain management. We're really focusing on opioid management. So a study and another, on primary care effort has really found that a typical primary care practice, a typical primary care visit is 20 minutes. That's the average. And in that 20-minute average, an average of 7 clinical problems are addressed. So that's, your high blood pressure, your mammogram, your diabetes, your influenza vaccine. Maybe you're not sure if you want it, so you have to counsel about that. Should we do some shared decision making about colon cancer screening methods? And then we're going to talk about your migraines, and then wait a minute, oh yeah, we have this opioid consent to fill out, and oh yeah, you need your prescription. So where's the time to talk about pain and patients' pain management? It's just going into this opioid black hole. And then finally, this is opioid therapy as sort of a moral imperative or a religious commandment, right? So we normally think about therapies, we think about evidence for benefits and harms and weighing those things, and is this the right treatment for the right patient? Well, that's not how we've been thinking about opioids all along. We assumed effectiveness, and we were taught that we had a moral responsibility to use these supposedly effective, strong drugs for chronic pain. And this is a barrier because we can talk about evidence all day long, but that doesn't really respond to a moral argument. So what is our moral response to the argument that, opioids are something that we really owe our patients? This is important stuff. So those are my barrier slides. And I'll try to be a little more optimistic now. So you've already had a lot of background about opioid prescribing in the US, and I'm not going to talk a lot about opioid prescribing in the VA, but we do it. And it has important consequences. So this is actually a quote from one of Amy Bonnard and colleagues' papers that found that VA patients, are probably disproportionately affected by overdose deaths. So about twice the rate of accidental poisoning as the general population. And just as in the general population, opioids is the big contributor to those accidental deaths. And this is from a study by Mark Edlin, just looking at our prescribing of opioids in VA. They found about 1.4 million veterans with a chronic pain diagnosis, and about half of those had received at least one opioid prescription in that year. It's 2011 in particular. The vast majority of those were getting opioids regularly or semi-regularly, at least more than once. So the median day supply among those, that's 0.7 million, was 120 days. But the median dose was relatively low. So on average, 21 morphine equivalent milligrams per day supplied. And this table just really shows the distribution of doses. And what I wanted to highlight is it's really that top decile that is getting higher dose opioids. The bottom 90% here are really receiving relatively low dose or moderate dose opioid therapy. At the 90th percentile, the dose was 62 morphine equivalent milligrams per day. So not huge numbers receiving very, very high doses, 90% receiving low to moderate doses, but on a pretty regular basis. So that's what most VA prescribing looks like. We do a ton of it, and it's mostly lower dose. So now I'll shift gears real briefly and talk about the National VA Opioid Safety Initiative. This has been rolled out in the last couple of years. And this is a nationwide initiative coming from Washington, D.C., and that all facilities within VA, all leaders of local facilities and regions in VA are accountable to this initiative. So what it is really is it's a set of some data tools. First, there's an opioid safety initiative dashboard that monitors a variety of different opioid prescribing metrics. And those reports are available. Anyone in VA can go to this website and find how their facility matches up against their region, their neighboring facility, the national levels. I can look and see how the Minneapolis VA compares with the Ann Arbor VA. It's all quite easy to do for those comparisons. Then there are opioid panel reports for primary care physicians and teams. They provide lists of all the patients on the team who are receiving opioids, what their average dose is over time, when the last drug screen was, all these kinds of things. So, those data basics that are required, really, I think, for change. And then it provides nationwide targets that all VA facilities and health systems are expected to meet. These were initially issued in April 2014, and then they were revised and reissued in December 2014. And I won't talk about this a lot at all, but these are the national VA goals. There's 9 of them, somewhat abbreviated to fit on one slide. Basically, they focus on increasing use of UDT, or urine drug testing, facilitating use of the prescription drug monitoring programs in the states. Many of you may know that until recently, VA was not reporting to prescription drug monitoring programs, and there were some VA barriers to using them, but those have been really eliminated at this point, and now VA is encouraging and working on increasing use. And then VA is also focusing on identifying high-risk patients as well as high-risk regimens. So the combination of opioids plus benzodiazepines and long-acting opioids and high-dose opioids are the targets. And then finally, there is some effort to increase accessibility of behavioral therapies for chronic pain and complementary and alternative medicine therapies, or CAM. I think Mark Ilgen is going after me. He's going to talk a little bit more about the national VA situation and how that has and has not changed as a result of the Opioid Safety Initiative. In Minneapolis, we had a little foreshadowing of this. In 2011, some primary care champions really started working on a population-level quality improvement initiative to decrease high-risk prescribing of opioids. And they had 2 fairly simple objectives. The first was to eliminate high-dose prescribing, which they defined as more than 200 morphine-equivalent milligrams per day. Why did they pick that number? Well, because they looked at how many patients were above each of a number of thresholds. And this was a target that was probably reasonable, that might be accomplishable. So that's why they picked that. And the second goal was to phase out use of OxyContin, otherwise known as oxycodone SA. There's no actual evidence that oxycodone sustained action is responsible for more addiction or overdose than other opioids, but it certainly is more expensive. So, and doesn't seem to carry specific benefits. So that was a second goal. This is what the Minneapolis VA health system looks like, just so you know. In 2011, we had 1 major hospital in Minneapolis, we still do, and 11 suburban or rural clinics spread out across the state. That's the for those of you who don't know where Minnesota is on the map, that's the Canadian border at the top and the Iowa border at the bottom, and that little yellow chunk is western Wisconsin. So we have 11 clinics spread out over Minnesota and western Wisconsin. And in 2011, we had about 68,000 patients enrolled in primary care. About 60% of those at the main hospital, and the other 40% spread out at all these community-based outpatient clinics. So this is the storytelling part. Again, this wasn't a research study. So what did this team start by doing? They really started by meeting with leadership and stakeholders. And that was trying to get everyone on the same page. We want to reduce the risk of our opioid prescribing as a facility, as a health system. How are we going to do this? This started with the clinical leadership, but many important stakeholders were brought into the fold. And this includes the patient representatives, so those people who take complaints from patients and mediate those complaints with providers. They were seen as a very important partner in this from the beginning. Veteran service officers at the county and the state, these are also people who are going to hear from veterans and need to respond in a way that's helpful and not undermining a positive initiative, as well as the more conventional kinds of stakeholders you might think of, the pharmacy department and nursing and the inpatient side, the emergency room, all these different places. There were 6 educational sessions held for primary care providers focused on changing opioid prescribing and other kinds of pain management. And then the clinical pharmacy group really prepared as well because they were going to be responsible for a lot of this work. In VA, clinical pharmacists are embedded within primary care, so most clinics do have a clinical pharmacist assigned, either present in the clinic or nearby, assigned as their clinical partner to help with medication management. The program was implemented in February 2012, and really the way it was rolled out is, there was a letter that was a very definitive letter that came out from the chief of staff, and this is the problem, the overdose epidemic. It's been identified that this problem has been associated with high dose prescribing, and we're going to eliminate that high dose prescribing in our system. And so very clear that everyone was on board. There were phone numbers to call, resources, any questions, how do you get it answered? But, everyone is expected to reduce doses and to convert patients from oxycodone SA to other medications. The patient lists were distributed to the primary care providers with instructions that they ought to meet with their pharmacist and develop a taper plan, call their patients in for a visit to discuss the medication, and then work with the pharmacist on implementing the plan. Performance measures were developed and publicized. I'll show you those. And there were some patient pain education classes developed. These were about half-day classes that included participation by pharmacy, physical therapy, psychology, and a number of other nursing, medicine, other healthcare providers, really to introduce patients to a new way of thinking about pain and different options other than medications for pain management. And then there was a second phase, and that was an opioid review committee. So as other speakers have noted, there's certainly differences in how different providers prescribe, and we did have certain primary care providers who were responsible for more high-dose prescribing than others. And so this was really, the Opioid Review Committee was implemented to work with those higher prescribers to bring them into the fold. So again, this is not research, this was quality improvement, but prior to the start of the survey, or prior to the start of the initiative, there was a survey of the primary care providers to really understand what they were thinking and what some of the specific barriers might be locally. And I think I won't talk about all of this, but I think a few things worth mentioning are, look at how few are satisfied with the care they're providing for their patients with chronic pain, 9%. And how few say they have adequate training to care for patients with pain, 32%. When the program was rolled out, there was a meeting and some breakout sessions to talk about hopes and concerns. And really, these are the kinds of hopes and concerns that shouldn't be a surprise. I think primary care providers were worried, what do I do for patients who have no more options? What if my patients become angry or suicidal? What if I can't access other treatment modalities for them? But they did say, this may be real backup and support to help us do what we've wanted to do anyway. And that would be to move away from overuse of opioids. These are what those individual patient lists look like. Nothing very exciting there. These are what the performance measures look like. So this is the number of patients on high-dose opioids. And the gray column there, that's provider number. It's semi-de-identified, but not really, because we all had the crosswalk. And really the idea here is that you can compare yourself to your colleagues and see how you might be an outlier. So you feel maybe a little bad about yourself if you're in red. And this is what our outcome looks like. So these are the number of patients receiving a daily dose above the threshold. And remember, the target here was to get everyone under 200. And so all the way on the right, that's over 400, because some of the patients were on very high doses. And it takes a while to come down if you're on 1,000 morphine equivalent milligrams a day. So, but near elimination of those extreme doses. And the numbers on doses over 200 really dramatically reduced. I think what's kind of interesting is that we more than halved the number on more than 100 morphine equivalent milligrams per day. So that came way down too. So even though that was not a target here, there was an overall trend to reduced opioid prescribing. And across the facility, the daily dose went down 47% among those receiving a prescription. A second goal was to get rid of oxycodone SA in the system, and as you can see, that pretty much happened. The main point of the slide is just to show that it didn't shift to other long-acting opioids. And this is our post-survey from the same providers. I'm highlighting those top numbers to see that we didn't make a huge dent there, right? One thing that did change was that there was a fear that prescribers would receive a lot of pressure from patient representatives or the administration. And I think as a result of that initial stakeholder effort, that didn't happen. This is another outcome slide. So our local newspaper had a two-part investigative series focused on our pain and opioid management that was extremely unflattering, highlighting a variety of terrible outcomes among veterans, some suicides, some overdoses, heroin overdoses, that were, by the paper at least, attributed to this change in practice. Now, unclear that any of the specific cases were directly related. In fact, none of them were, but that was certainly the impression made in this newspaper series. And the conclusion of the Star Tribune editorial was that really we had swung too suddenly in the other direction after the national spotlight on overprescribing. And veterans should not be imprisoned by pain because doctors are unwilling or unable to prescribe the medications they need. So this is that moral barrier that I think we still face. So in summary, we did accomplish some things. There was a real alteration in primary care prescribing practices and a clear change in the system-wide standard of care. The persistent challenges were in overall the quality of pain management, availability of non-pharmacologic pain management options, and in the public and patient perceptions. I don't think we won all those battles. And the unknown is the patient outcomes. Are patients better off? Like most healthcare systems, since that's not an easily available item in a data set, we don't know. We don't have survey data on how our patients did. I think anecdotally, we know that some people were very angry and dissatisfied, and others were actually really satisfied and felt better, felt that they were doing better after this kind of dose reduction. This is my leaving slide is another patient quote, talking about his experience with primary care. That there's really no conversation about pain. And this patient was very perceptive. My personal belief, and my current doctors, the best I've seen over these 4 decades, is that they're at a loss at this. Do we know what we're doing with chronic pain management yet? So I think implications are that systemic efforts can reverse opioid prescribing patterns. But, the IOM in 2011 identified the real challenge, I think, and that's to transform our understanding of chronic pain and how we should be preventing, assessing, and managing it. That's that. Thank you. I think I used up my whole time, so.
Thank you so much. I really enjoyed that. My question is, in your pre and post after the program, you suggested that maybe you didn't have an impact, but there was a 3-fold increase in the percentage of doctors who said that they were happy with their how they're they were managing pain, and a tiny little reduction in the percentage who said that they felt confident that they were well trained. But I'm wondering if you basically, with the program, made them aware of how little they actually do know, and made them realize that they really need more training, so that that's not a negative. It's that you're making them aware that, yes, in fact, I really don't know what to do, but they're happier with what they're doing. You must have done something good.
I think, it went from like 9% being satisfied with the quality of chronic pain care to something like 25% or 30%. So there may be some victory there, but it's not very satisfying, is it? This is us providing the care, and 75% of us think that we're not happy with the care we're providing. It's really, I think that's a really important statement about I think in primary care we recognize that we really do need to learn something different. We need a new approach. This approach to date where, we measure the pain intensity and then we prescribe opioids in a futile attempt to decrease the pain score, that's just not got us anywhere good. So a lot of primary care providers, I think, are asking, well, now what? And every time I give a talk, that's always the question, if the talk is focused on opioid therapy. Well, what am I supposed to do then? Because this was supposed to be the thing that sort of was a one-size-fits-all pain management approach, and it doesn't turn out to be that.
How sustainable has the changes in practices been, and has it really been a culture change?
I think it has really been a culture change, and I didn't update the numbers, but they are currently lower, I believe. So those very high dose people who are just coming down maybe 20 milligrams a month, they're still coming down, and there's a decrease, I think, in new starts, and certainly a decrease in escalation. And I think it's really, in large part, this was a painful process. It was difficult, and there was a lot of discomfort, I think, involved. But on the other side, at least from the primary care provider perspective, I think there's a lot of relief that, we don't have to redo this argument all the time. It's kind of, there's an understanding that that's kind of the way we used to do it, and we don't really do it that way anymore. So I think it's better on the other side. And we've actually implemented since then a multidisciplinary pain clinic and a variety of other non-pharmacologic pain management resources. One would wish that stuff was in place before we started this, but you never get everything you want when you want it. So I think there's a lot of progress, but it's slow, and this is a lot of this is many years of practice that is being undone.
To follow on Amy's question, have you seen the same sustain or even bump up in the patient satisfaction? Because it's an adjustment not just for the providers, but one would hope after you start to change the provider culture some, that the patients will be hearing the same responses enough that there will also be a change in expectation. And then some of the concern over the Press-Ganey scores going down will be mitigated when there is some realization that this is a change in practice, not a change in an individual physician.
Yeah, and I don't know. So VA has its own standard satisfaction measurement, which is the SHEP survey for those of you who are in the VA. I'm actually don't know if there was ever a change in our overall SHEP sort of numbers as a facility. I think, I am not sure that the way this was rolled out was always as patient-centered as it could possibly be. I think one concern I always have about opioids is that sometimes we really emphasize the patient role in the opioid epidemic and opioid misuse and in high-risk patients and in all patient behaviors, when really, in my view, this is an entirely iatrogenic health system, provider-driven problem that our patients are reacting and responding to, sometimes in adaptive ways and sometimes in maladaptive ways. But sometimes I think that the message patients got was that, we're taking this thing away from you. It's hard to do these things well all the time. So just a couple of weeks ago, I was following a man down the hall, and he was talking to the volunteer pushing him in the wheelchair, and he was saying that they cut his meds way back, and the volunteer said, "Oh, why would they do that to you?" And he said, "Well, I don't know. I think it's some Washington D.C. policy or something." So this was not probably what we were going for.
I have one of those questions from the Twitter audience, which is a similar thing about communication problems. And the person, I don't know their gender, is saying they believe there's a perception on the part of the doctors that if pain meds are reduced, the patient wasn't really in pain to begin with. That it's the patient's perception of what the doctor's thinking, but that it's there and it's real, because the chronically ill are all malingerers who want to go on welfare and Social Security because that's fun.
Yes.
So that's from the
We
Twitter
know there's
audience.
all this stigma about both chronic pain and addiction. And, as has been said earlier today, this idea that there are good, truthful pain patients and bad, lying pain patients. And, these things are just really destructive. And underlying it, too, there's this odd sort of assumption and I think misperception that opioids are really great drugs that work really well. You can look at a lot of studies and a lot of talks, and often the first slide will be like, well, we know they're efficacious and strong, useful drugs, but they have these downsides. We don't really know that. We really, and I think, as Michael's slides pointed out, most patients with chronic pain who are on these medications aren't getting a great deal of relief. And those who are doing really well, again, would they be doing well off the medications? We just don't know. And so we have such insufficient information. And, unfortunately, I do think patients often get these, there's sort of a blaming response, blaming the victim sometimes.